Good evening. This is Dr. John Bennett broadcasting from Miami. Tonight we have another in the continuing series of Parkinsonism education hangouts with Dr. Abdul Rana, neurologist and world-renowned Parkinsonism educator from Toronto, Canada. Good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you this evening?
Very good. If it wasn't for the mass transit of Miami, which was starting a little late. Okay, let me the topic tonight is multiple system atrophy and Parkinsonism, part one, and we're going to do part two tomorrow night. And I'll start things off with a question. What is the historical background of multiple atrophy?
Multiple system atrophy is a sporadic neurodegenerative disease of unknown cause. The term multiple system atrophy was put together in 1969. And before that, the multiple system atrophy was under three categories. Striatonigral degeneration, which has pyramidal tract signs with antrocolus, the olivopontocerebellar atrophy, which has tremor in cerebellar signs, and Scheidegger syndrome, which has a predominant autonomic dysfunction. In 1989, the glial cytoplasmic inclusions were found in brains of MSA patients. And these inclusions were found in all three categories of the disease. So this led the physicians to think that these three conditions were part of one big condition. And therefore, they named it multiple system atrophy. It has multi-system neuronal degeneration. In 1989, these cytoplasmic inclusions which were found, later they were found to be known as consist of alpha synuclein pathology. And therefore, since then, the multiple system atrophy is termed as a synucleinopathy, like idiopathic Parkinson disease or Lewy body disease. So there has been a progression or evolution from three different categories of striatonigral degeneration, olivopontocerebellar atrophy, and Scheidegger into one term, and then finding of the glial cytoplasmic inclusions in brains of these patients, and then finding of the alpha synuclein staining in these patients.
How common is multiple system atrophy?
The exact incidence and prevalence of multiple system atrophy is difficult to determine due to various reasons. One is that in some cases, it could be difficult to differentiate from idiopathic Parkinson disease, and it could be lumped together with idiopathic Parkinson disease or not diagnosed properly. In other cases, the lifespan may be short, and these cases may not come into attention. However, about 2 to 3 cases per 100,000 population is considered the MSA incidence. The average is about 2 to 5 cases per 100,000. And the mean survival is usually between 6 to 9 years in these patients.
Okay, what is the common presentation of multiple system atrophy?
Multiple system atrophy affects both men and women, and the most common age for onset is 6th decade. And these patients have combinations of many different systems involvement. They have Parkinsonism, they have cerebellar ataxia, they have autonomic failure, they also have pyramidal signs. And most experts divide multiple system atrophy into 2 main subcategories or 2 main types. One is multiple system atrophy Parkinsonism subtype, and the other one is multiple system atrophy cerebellar type. The multiple system atrophy Parkinsonism type is the more common one. It occurs in about 80% of these patients, and they would have a jerky postural tremor of both upper extremities, and sometimes they could have a very mild, subtle resting tremor as well. So these patients, in addition to having this jerky tremor or a resting tremor, as well as bradykinesia and rigidity, which are the main findings of this type of multiple system atrophy, these patients may have a dystonia involving the craniocervical region or orofacial region. They might have high pitch dysarthria with a high pitch sharp type of voice, and they do have postural instability as well. But as opposite to progressive supranuclear palsy, the postural instability does not usually occur in the beginning of the course of the disease, but it takes few years before all of the symptoms or signs of multiple system atrophy Parkinsonian type would develop. Now, these patients who have multiple system atrophy Parkinsonism type, they might have a transient improvement with the levodopa, but the improvement is not as robust as in patients with idiopathic Parkinson's disease. About 1/3 of patients would report some response, although the response is mild. In about 90% of the patients, levodopa is not able to result in any long-term improvement. So some of these patients could develop the orofacial or craniocervical dyskinesia as a result of levodopa in the subtype of multiple system atrophy Parkinsonism type. Whereas in multiple system atrophy cerebellar type, these patients mostly have ataxia of gait and limbs. So they have that finger-nose dysmetria. So when they reach target, you can see their dysmetria becomes very prominent. And in terms of speech, they have the scanning of speech, which is quite characteristic of cerebellar involvement. And in addition to this, they do have oculomotor disturbances as well. The disturbances of eye movement, such as nystagmus, engaged nystagmus, or post-target nystagmus. Now, dysautonomia, the autonomic dysfunction, is seen in both types, the multiple system atrophy Parkinsonism type and the multiple system atrophy cerebellar type. And the autonomic dysfunction may start many years before the signs of gait or balance problems. Men, most of the time, have sexual dysfunction with erectile issues. They cannot attain erection. Some of the patients in the beginning may just have mild urinary symptoms, but most of the patients would develop urinary incontinence, or some patients may develop urinary retention as the disease progresses. And this happens usually early in the course of the disease, as compared to idiopathic Parkinson's disease, where the urinary problems occur in the late and they are much less severe. As compared MSA, the urinary problems are much earlier, they are much severe, and these patients also have constipation, but constipation occurs about at a similar rate as patients with idiopathic Parkinson's disease. The orthostatic hypotension, the postural dizziness, drop in blood pressure by assuming an upright position from a sitting or a lying down position. Usually it's a drop of systolic blood pressure of 20 and diastolic of 10 when the patient assumes an upright position. And so this orthostatic hypotension, it's one of the most significant sign of multiple system atrophy cardiovascular involvement. So these patients feel quite dizzy when they stand up, and they may have recurrent syncope in about maybe 15 to 20% of patients. They may have declining level of consciousness, and many of these patients may start falling later. The orthostatic hypotension is also seen in other conditions beside multiple system atrophy, such as idiopathic Parkinson's disease, but it is later in the course of disease, it is less severe, and it is less common as compared to multiple system atrophy. And orthostatic hypotension could also be seen in patients with Parkinson's disease who have dementia or diffuse Lewy body disease.
What are the indicators of multiple system atrophy?
This is a very important question, because in the beginning of the presentation of the patient, it may be really difficult to determine that this is multiple system atrophy. So there are certain signs or suggestions that if you go back in history and examination, so you would see that these findings may be found in these patients much before their presentation to a neurologist. So they might have history of feeling of coldness in their hands and feet. They have feeling of hands and feet going cold when the room temperature is fine. Sometimes they could have a purplish discoloration of their hands and feet, or their legs or arms. And if you put a pressure, it could blanch easily, but when you relieve the pressure, there is a delayed circulatory return. So that could also be an indicator of MSA. And then some patients may have a forward flexion, the forward bent neck, which is also referred anterocollis in some patients. Other patients could have inappropriate laughing or crying without any obvious reason. Some patients may have their trunk bent towards one side, which could be referred as a Pisa syndrome in some cases. And these patients have a relatively rapid progression. Usually, they would become wheelchair dependent within 10 years after the onset of the disease. When these patients are sleeping, you may be able to hear a stridor on inspiration. So inspiratory stridor is common in these patients. And within first 3 years of the onset of the disease, they may have postural instability and they may have recurrent falls. Whereas in idiopathic Parkinson's disease, it may take a bit longer than 3 years. Then their dysarthria is flaccid. Their speech is quite flaccid with some scanning, and they might have dysphonia, and they might have dysphagia sometime. These patients also have REM behavioral disorder, the RBD, which is due to the intermittent loss of atonia of the REM sleep. And these patients would act out on their dreams. They may be reported by their spouse that they were flailing their limbs or crashing in sleep, or they were yelling, shouting, screaming, or trying to punch the spouse during sleep. So these REM behavioral disorders could start much before the other symptoms of multiple system atrophy. Sleep apnea is also not uncommon in these patients, and this jerky postural type of tremor, which we discussed, that could be seen in the hands and fingers of these patients, and orofacial dystonia, as well as dyskinesias. And sometimes they could have a Raynaud type of phenomena with the exposure to cold weather, like in the other patients. So beside this, the core symptoms in these patients are the urinary dysfunction, sexual problems, and postural hypotension.
What are the pathological changes seen in multiple system sclerosis?
In case of
multiple system atrophy.
I will just I'll come to this. Just okay. I'll try to finish that.
Okay. I'm sorry.
So urinary dysfunction, as we were discussing, it occurs in almost all of the patients with multiple system atrophy, almost all of the patients. It may include urgency of urination, nocturia, urinary retention in a less number of patients, but incontinence could happen in in a larger number of patients. Now, similar symptoms could be caused by prostate hypertrophy, UTI, or diabetes, or certain medications. Therefore, these patients do need to see a urologist, and they need urodynamic studies to to differentiate this from the prostate problems. Some of the anticholinergic medications, such as oxybutynin or tolterodine, they may be able to help these patients to decrease their bladder issues. These medications, in some cases, could cross the blood-brain barrier and cause the delirium. With respect to sexual dysfunction, which is also a core symptom of multiple system atrophy, so almost all patients, eventually men, would develop erectile dysfunction. The women may have a decreased libido. So not only they have erectile dysfunction, but also they are slow when they perform the sexual activity. And this may lead to anxiety, depression, and like a vicious cycle. So they may even notice further issues with the performance. Some of these patients could develop a poor self-esteem, and they might be depressed due to this reason. With respect to the orthostatic hypotension, that could lead to loss of consciousness, patients could fall, and autonomic dysfunction is the main cause of partial hypotension in these patients. And the autonomic dysfunction is different in case of idiopathic Parkinson's disease and in case of multiple system atrophy. In case of multiple system atrophy, there is more central involvement, whereas in case of idiopathic Parkinson's disease, there is more peripheral involvement. And these patients, when they stand up, they may not be able to maintain their balance, and they might fall. The orthostatic hypotension not only is seen in cases of multiple system atrophy, but many patients with Lewy body disease also develop. With respect to your question of the pathological changes in multiple system atrophy, the hallmark of multiple system atrophy is the presence of those alpha-synuclein positive cytoplasmic glial inclusions, which are gyrophilic. Sometimes they could be oval, at other times they could be like half moon, or they could be conical in shape. And they are usually composed of a 20 to 30 nanometer multi-layer tubular filaments. Now, these inclusions could be found in basal ganglia, supplementary motor and primary motor cortex, as well as reticular formation in pontocerebellar system. With respect to multiple system atrophy Parkinsonian type, the main loss is at the striatonigral system. So main neurodegeneration is involving the striatonigral system. There could be a less severe degeneration of the oligopontocerebellar system in these patients. In patients with multiple system atrophy Parkinsonian type, they may have the atrophy of the putamen, and the putamen may be discolored, and these patients may have the loss of neurons in the pars reticularis, which remains normal, but pars compacta, they may have loss of neurons with the neurodegeneration. In case of multiple system atrophy cerebellar type, these patients have main involvement of the oligopontocerebellar system, and there could be a less severe involvement of the striatum and substantia nigra. The loss of there is loss of the pontine neurons. There is atrophy of the basis pontis, and also those transverse pontine fibers may be seen to be destroyed or degenerated. The brainstem nuclei could lose their pigmentation. They could become pale, and there could be some atrophy of the cerebral cortex as well. Now, in these patients, they have three main features: the autonomic failure, the urinary, bowel, and sexual dysfunction, and the orthostatic hypotension. The autonomic failure in the MSA patients, when you look at the pathology, that could be due to the loss of neurons in the dorsal motor nucleus of vagus, locus coeruleus, as well as catecholinergic neurons of the ventrolateral medulla, which are the central changes. With respect to the urinary, bowel, or sexual dysfunction, that could be due to the neuronal loss in the parasympathetic preganglionic nuclei of the Onuf nucleus, which is at the level of S2 and S3. And there could be loss in the inferior intermediolateral nucleus between S3 and S4. The orthostatic hypotension, which is also a hallmark of this disease, it could arise from the degeneration of the sympathetic preganglionic neurons in the intermediolateral column of the spinal cord. MRI in these patients could show a hyperintense rim around the putamen. There could be atrophy of the putamen, and sometimes the putamen could be hypointense if you compare that to the globus pallidus. And there's a sign which is called hot cross bun appearance. It could be seen in the palms, cerebellum, and there could be putamen atrophy, and there could be some hyperintensity of the middle cerebellar peduncles. Now, this hot cross bun sign is not specific for MSA, unfortunately, and it could be seen in spinocerebellar ataxia type 3, Macheru-Joseph disease, or some other conditions. Therefore, it remains sensitive but not specific.
Very good. Anything else to cover in multiple systems atrophy before we close?
Multiple system atrophy may be difficult to diagnose when you see these patients initially or on a first visit. So I think it's important to keep in mind these symptoms and maybe reassess these patients, and unless a person is sure. So we should wait, and we can tell them that this seems to be Parkinsonism, one of the type of Parkinsonism, and but in some cases it could be difficult to differentiate from progressive supranuclear palsy, the early onset, or maybe some idiopathic Parkinson disease with atypical features. So I think reassessment may be helpful, and we will discuss the diagnosis and treatment in next session, and then we could go over the differential diagnosis and how to reach the best diagnosis in these patients.
Very good. Thank you for covering multiple systems atrophy tonight, part 1. And we'll continue part 2 tomorrow night. All these videos are on the channel, Parkinsonism TV, for patients and doctors. Thank you very much, Dr. Rana.
Thank you, Dr. Bennett.
Okay, good night.
See you tomorrow.